Hello, I'm Dr. Julie Heimbach. I'm a transplant surgeon and the surgical director of liver transplantation at Mayo Clinic in Rochester, Minnesota. And I'm here today with Dr. Sumaira Rizvi. And we are going to speak to you today about Hilar Cholangiocarcinoma and the role of liver transplantation, specifically what patients need to know.
Cholangiocarcinoma is cancer of the bile ducts. It's a rare cancer that has an incidence in the United States of about 1.2 per 100,000, although that number is higher in Eastern Europe as well as Asia. Overall, the incidence of cholangiocarcinoma appears to be increasing worldwide. Cholangiocarcinoma is divided into three subtypes based on the location of the tumor within the bile duct. Approximately 40% of cholangiocarcinomas are intrahepatic or within the liver. Intrahepatic cholangiocarcinomas rise above these large bile ducts that you see here. And most patients tend to present with a large intrahepatic mass lesion incidentally, or if, let's say, if they're being evaluated for abdominal pain and may have a CT scan that shows a liver mass that turns out to be an intrahepatic cholangiocarcinoma. The remaining 60% of cholangiocarcinomas are outside the liver, with the majority being perihilar or hilar cholangiocarcinomas. The hilum is the point of joining of the left and right hepatic ducts, and tumors arising in this region are referred to as perihilar or hilar cholangiocarcinomas. Tumors arising in the lower part of the common bile duct are known as distal cholangiocarcinomas. And as Dr. Heimbach mentioned, today we will be focusing on hilar cholangiocarcinoma. Hilar cholangiocarcinoma, or CCAs, they tend to have a tropism or affinity for bile, which means that they tend to grow in a longitudinal dimension along the bile duct wall. Their propensity to do this can make the diagnosis of early stage hilar cholangiocarcinoma quite challenging, as there is an absence of a mass lesion on imaging studies such as a CAT scan or an MRI. As the tumor advances, radial growth occurs away from the bile duct in a horizontal manner, and this may result in a mass lesion which can be picked up on imaging studies like a CAT scan or MRI. In the Western world, a primary risk factor for hilar cholangiocarcinoma is primary sclerosing cholangitis. The lifelong risk of developing cholangiocarcinoma in PSC patients is about 10 to 20%, and about approximately 40% of patients who have CCA in the setting of PSC are actually diagnosed with cholangiocarcinoma within 1 to 2 years of PSC diagnosis. So what that means is it's when PSC is initially diagnosed that we need to have a high index of suspicion for cholangiocarcinoma occurrence. Hepatobiliary fluke infection tends to be a risk factor for cholangiocarcinoma in Southeast Asia. This is a region which actually has one of the highest rates of cholangiocarcinoma development. Hepatobiliary or liver flukes are parasites which cause chronic inflammation of the bile ducts, and they're known as carcinogens or cancer-promoting agents. Bile duct cystic diseases or choledochal cystic diseases are rare congenital abnormalities of the pancreatic and biliary ducts that are associated with a higher risk of cholangiocarcinoma development. It's important to note, though, that most patients with hilar cholangiocarcinoma have no identifiable risk factors. As far as the symptoms and signs of hilar cholangiocarcinoma are concerned, most patients tend to present with painless jaundice. This is a condition in which yellowing of the eyes and skin occurs. So this typically tends to be the first sign that leads the majority of our patients to seek medical attention. About 10% of patients present with bacterial cholangitis, which is an infection of the bile ducts. And patients may also have non-specific symptoms and signs such as weight loss, cachexia, which is muscle wasting, abdominal pain, and malaise, which is a general feeling of being unwell or ill. The diagnosis of hilar cholangiocarcinoma is quite challenging, and we utilize a wide variety of testing modalities to help arrive at the diagnosis of hilar cholangiocarcinoma. The most common laboratory test which is used is the level of the carbohydrate antigen 19-9 or CA19-9. This is a tumor marker which can be quite high in cholangiocarcinoma. Levels of bilirubin, which is a substance found in bile, can also be high in patients if they have a biliary obstruction or blockage of the bile ducts by a tumor. Imaging studies that we commonly utilize are computed tomography or CT scans, which is your typical CAT scan, and magnetic resonance imaging or MRI with a special technology known as magnetic resonance cholangiography or MRC, which is a non-invasive way of outlining the biliary tree so we can see strictures, which are points of narrowing in the bile ducts. Endoscopic ultrasound, or EUS, is emerging as a valuable tool for both the diagnosis as well as the staging of hilar cholangiocarcinoma, particularly in patients with unresectable hilar cholangiocarcinoma who are being considered for possible liver transplant. Via this technique, lymph nodes are sampled for the purpose of staging. Now, spread of hilar cholangiocarcinoma to the lymph nodes is important in staging because patients who have this have a worse outcome, as this is a contraindication to potentially curative options such as liver transplant following chemoradiation therapy, which is our protocol here at the Mayo Clinic. Endoscopic retrograde cholangiography, or ERC, is an essential tool in both the diagnosis as well as the management of hilar cholangiocarcinoma. Via ERC, the biliary anatomy is delineated. We can outline the bile ducts, see where strictures are. This also enables acquisition of biliary brushings for subsequent cytological or FISH analysis. And from a therapeutic standpoint, ERC enables dilation and stenting of biliary strictures. One of the biggest challenges in the overall management of hilar cholangiocarcinoma is making the actual diagnosis. And there are several reasons for this. The tumors tend to be very desmoplastic, meaning they're very dense, fibrous tumors, and they grow along the bile ducts, and especially in the early stages, mass lesions may be absent, and this makes these tumors difficult to access via ERC. Additionally, these tumors also tend to have what we refer to as a paucicellular nature, which means that few cancer cells may actually be present to have a cytological analysis. Due to these reasons, endoscopic brushings or biopsies may actually be negative even in patients who have well-established tumors. The other reason is something mentioned earlier, which is that these tumors tend to have a tropism or affinity for the bile ducts. So they grow along the bile duct, and there may be, as a result of that, there may be absence of a mass lesion on imaging studies such as CAT scans or MRIs. Even in patients who have a blockage of the bile ducts as a result of these tumors. CA19-9 is a tumor marker that is used utilized in the diagnosis of cholangiocarcinoma. And this one study showed that if using a cutoff value of 100 units per ml for the CA19-9, the sensitivity and specificity were 75% and 80% respectively, which is much higher than the numbers we attain by using the typical cutoff value of about 37 units per ml. So using the higher cutoff value has greater utility in helping us diagnose cholangiocarcinoma. As mentioned earlier, imaging studies that are used to make a diagnosis of cholangiocarcinoma include MRI, MRC, as well as ERC. To your left is an MRI picture showing hilar mass. So this is the lighter area that you see here in the darker background, which is the liver. To your right is an ERC picture showing a hilar mass causing separation of the bile ducts. Now, typically during ERC, contrast should flow smoothly and continuously through the bile ducts. And in this case, that is not occurring. So we know that a mass is present right here because of the abrupt stoppage of contrast flow, which indicates to us that the mass is causing disruption or discontinuation of the bile ducts because it's causing narrowing of these bile ducts. Brushings that are obtained during ERC are sent for conventional cytological analysis, and shown here are the different possible results that we attain. On the top left is a normal cytology specimen. The top right is an atypical cytology specimen. Now, atypical cytology is actually encountered quite frequently in PSC. And the reason for that is that there is underlying inflammation that causes the cells to have a reactive nature, and they appear atypical. By itself, atypical cytology should not raise concern. On the other hand, suspicious cytology is a concerning finding. About 34 to 42% of patients with PSC who have suspicious cytology and don't have a mass lesion, they may ultimately be diagnosed with cholangiocarcinoma. And positive cytology is helpful because when present, it confirms the diagnosis of cholangiocarcinoma. There are several limitations to conventional cytology, and a few of these have been mentioned earlier. And these tumors, they tend to be very dense fibrous tumors in difficult to access areas, so the specimen may not be adequate. The tumors are paucicellular, meaning they contain few cancer cells, and for these reasons, the cytology specimen that's obtained may not be adequate for analysis. The chief limitation of cytology is that it has a low sensitivity for detecting cholangiocarcinoma when it is the only finding, and that sensitivity is about 10 to 40%. What that means is that there's a high chance of having a false negative result, or having a negative result in a patient who actually has underlying cholangiocarcinoma, meaning missing cancer. Therefore, a negative cytology does not rule out the presence of underlying cholangiocarcinoma. The other concern is that in the setting of PSC, there's a lot of inflammation and reactive cells that are present, and these can mimic cancer cells. The primary advantage of cytology is its high specificity of about 97 to 100%. And what that tells us is that when cytology is positive, it is very helpful because it confirms the diagnosis of cholangiocarcinoma. Brushings obtained during ERC are also sent for fluorescence in situ hybridization, or FISH analysis. What is FISH? This is a technique that utilizes fluorescently labeled DNA probes that are targeted to chromosomal locations or loci that are known to be altered in cholangiocarcinoma. So there's 4 loci that we have probes for. On FISH analysis, the possible findings are normal or disomy, and what that means is that there are 2 color signals for each of the loci. So you have 2 green for EGFR, 2 red for MCL1, and so on and so forth in this normal cell. The technical definition of polysomy, on the other hand, is that there are 4 or more epithelial cells with 2 or more signals in 2 or more of these 4 loci. So if you take this cell, for example, we have 4 color signals for MCL1, we have 4 color signals for EGFR, and 4 color signals for MYC, which and then the same holds true for these other 4 cells, and what that tells us is that this is meeting the definition of polysomy because we have more than 4 cells with more than 2 or more signals in at least 2 to 3 of these loci. Compared to conventional cytology, FISH analysis has a higher sensitivity for detecting cholangiocarcinoma in PSC patients. It's 47% versus about 18% in this one study that was done here. And however, this result is still subpar, even with using this advanced technique, because the sensitivity still remains below 50%. Combining these tests, though, is helpful. This one study showed that in PSC patients who had suspicious cytology as well as FISH polysomy, they all went on to develop cholangiocarcinoma in the ensuing years.
So once we've established the diagnosis of cholangiocarcinoma, which, as Dr. Rizvi said, can be really a challenge, the next challenge is how do we handle it? The standard treatment for cholangiocarcinoma at the hilum is to remove it with resection. So surgical resection has long been the standard of care. The problem with this is that there are many challenges. This is a very high stakes real estate. There's lots of important things going right through the hilum of the liver that limit our ability to successfully remove the entire tumor. So in fact, even when we think we can do it, we take the imaging, it tells us we think we can remove the tumor, it's possible to do so in the operating room only 70 to 80%. So we can only get it out 70 to 80% of the times that we go to the operating room with the intent to remove the whole tumor. Why is that? As I said, there are many important things that go right through the area where the tumor is, including the blood vessels to both sides of the liver itself, as well as the bile ducts. You need to preserve at least one side of the liver and the vessels and bile ducts to that one side of the liver in order to have the ability to remove all of the tumor safely. The other problem is that many patients present with unresectable disease. Even without even going to the operating room, we can see on the imaging that it's not going to be possible to remove it. So these are the main problems with resection for hilar cholangiocarcinoma. The tumor is small. It's really hard for us to see it well on imaging because it doesn't always make a big mass or a big lump that we can see in the picture. And this really is the big challenge. So how do we decide if we can remove it? Well, the first thing to know is that what we're talking about is tumors that are occurring de novo, meaning in a perfectly healthy liver. If the tumor is occurring in the setting of PSC, we think resection is not possible because of the underlying liver disease and the likelihood that the tumor is going to involve multiple areas of the bile duct in the setting of PSC. So when we're talking about tumors for resection, we're really talking about tumors that are arising in a healthy liver in someone with no previous liver disease. If it's involving both ducts on both sides of the liver, we can't safely remove it. If it's wrapping around the main vein, the main portal vein, which brings blood flow into the liver, we also think it's pretty unlikely that we're going to be successful. Sometimes we can still do this, but we'll have to do a reconstruction of that portal vein, and that's a possibility in selected cases. If it's involving the bile ducts to one side of the liver and then the blood vessels to the other side of the liver, again, this limits our ability to successfully remove the tumor with surgery. And finally, sometimes the tumor can cause atrophy, meaning the side of the liver can get really small on one side, and then it can involve structures like bile ducts on the other side of the liver. So if we've got one side of the liver has become very small secondary to the tumor constricting the blood flow, and on the other side it's involving the bile ducts or the vessels. Again, it's not possible to do a removal of the tumor successfully. So originally we thought liver transplantation would be the perfect solution. Since so few patients are eligible to have resection, transplant seems perfect. We don't have to worry about margins. We just have to take out the whole liver, which is where the cancer is. And we tried this a long time ago. We found that it failed miserably. As you can see in this slide from way back in 1991 involving a tumor registry data, patients who had transplant for liver transplant for cholangiocarcinoma really did very poorly over the long term, with very few patients surviving. And the primary reason that they didn't survive, unfortunately, was that the cancer came right back. So for the longest time, Hilar Cholangiocarcinoma was actually considered to be contraindicated or not something we could do in the setting of liver transplant. However, starting in 1993, at our center in Rochester and also another center in Nebraska, protocols were developed. And these protocols are what we're going to talk about today. So our current approach, which we've been doing since 1993, is for patients who have a resectable tumor, we go ahead with resection. For patients who have a tumor that comes in the setting of PSC, or who it looks like their tumors cannot be resected, we consider whether they can be enrolled in the liver transplant protocol. The protocol is basically involve very aggressive treatment called neoadjuvant, meaning this is delivered before some other therapy, which in this case would be transplant. So the neoadjuvant therapy involves both chemotherapy and radiation. The radiation is given in two different forms. One is an external beam, which means it's delivered from the outside after the tumor, as well as something called brachytherapy, which is a treatment actually where the radiation is loaded right inside of stents and delivered inside the bile duct, right where the tumor is. And while we're giving this radiation therapy, we're using a medication, a chemotherapy agent called 5-FU, or 5-fluorouracil, which is intended to make the radiation work better. It's called a radiosensitizing agent. After this is done, patients remain on a protracted course of capecitabine with an intent to keep the tumor from growing or spreading while we're waiting for transplant. Once we get close to the time of transplant, we have to actually do an actual surgery called a staging laparoscopy, which we do to be sure that the tumor is actually confined to the bile ducts. Before starting the protocol, we also have to be sure of this, but unfortunately, even with all of our pictures that we can do, we can't always see that the tumor has spread, because usually the spread is very limited right away. So we do the staging surgery in order to be sure that the tumor hasn't spread. Once we can confirm that, we can go on to transplant. The reason it's so important to be sure that the tumor hasn't spread is that transplant is really only helpful as a local therapy, meaning it's only removing the disease that's in the liver. If the tumor has spread beyond the liver, transplant can't help that because we will still have tumor left after the transplant. So in order to be eligible to have the transplant, first we have to try to figure out the diagnosis. And as Dr. Risby said, sometimes it's not possible to actually get a tissue sample to prove that there's cancer. So what we rely on is what's called a malignant appearing stricture, which means a narrowing on the bile ducts that we can see on imaging or ERCP. And if we see that narrow spot, then we also need to have at least one more of the following. If we can actually get a sample of the cells, that's ideal. But if we can't get that, then we also look at things like tumor markers or polysomy, or actually seeing a mass where the tumor we can see it spreading out as like a big lump that we can see on the CAT scan. The cancer needs to be in the hilum. If the cancer is down towards the end of the bile duct, then it's called distal cholangiocarcinoma, and this actually can just be removed with surgery, not with a transplant. And of course, as noted, cancer should be unresectable. What's really important is who cannot go into the protocol. Patients are excluded from the protocol if they've already had an attempt at resection, and also, very importantly, if they've had a biopsy that goes through the skins or through the intestinal tract, like the stomach or the duodenum, directly into the tumor. So it's really important to avoid this kind of a biopsy, because this actually spreads the tumor outside of the liver and makes further therapy like transplant not successful. Unfortunately, we've learned this by trying, that it doesn't work because the tumor will spread. So it's really important that the only way a tumor should be biopsied is from the inside of the bile duct, either with endoscopy or with a percutaneous tube that's placed directly into the bile duct. We don't want to do any other kind of biopsy of this tumor. It's also important that the tumor is not very large. Once the tumor becomes large, spreading out away from the bile duct more than 3 centimeters, then we know that it's much more likely to be spreading, and transplant is not likely to be successful in that scenario. And of course, if we already have found that the tumor has spread outside of the bile duct, we can't go ahead with transplant because transplant will not be successful. In fact, transplant will be harmful because of the anti-rejection medicine that we have to use after transplant that can make the tumor spread even further. It's also important that patients have not had previous radiation to the abdomen, because we can't do more radiation if you've already had radiation. We also need patients to be otherwise good candidates for transplant, so therefore we have to have no uncontrolled infections or other things that would preclude transplant. So what has happened so far here in Rochester is that we've actually enrolled 269 patients in this therapy. And you can see what has happened to the patients that have been enrolled in the therapy, with 168 proceeding all the way down to liver transplant. But what has happened to the rest of the patients, you can actually see that some of them are still waiting for transplant, or they've had their transplant in other places. But some patients have not been able to successfully make it to transplant, and that's primarily because the cancer, along the way, we have been able to see that it is spreading outside of the liver, and we can't be successful with transplant. Either that's before we do the staging surgery, or in about 20% of the cases, when we do the staging, we find that the tumor is actually in the lymph nodes. And again, or in other areas, other structures within the abdomen. And again, transplant can't be helpful in that scenario. So for the patients that have been successful and able to go on all the way to transplant, what we are able to accomplish is about a 70% 5-year survival for the whole length of the protocol, including 168 patients transplanted so far. It's also important to consider that not everybody makes it to transplant. As you could see on the previous slide, that sometimes patients are not able to go all the way to transplant. So we have to think about this from the start of the therapy. So if we look at everybody who's come in the door at 5 years later, how are patients doing? And even considering that 51% of the patients are still alive, the vast majority of those patients who are not alive are the ones that were not able to go on to transplant. This is a picture of what the liver looks like after after it's been treated. And we've actually removed the entire liver and transplanted the patient successfully with a new liver. And what you're seeing here is the old liver that we took out, that where the bile ducts are this white area. And this area here, which is kind of dark brown, you can see the injury from the radiation. So that you can see that the radiation is really aimed at doing a really aggressive treatment of the tumor, with the hope that we can actually even kill all of the tumor or the majority of the tumor while we're waiting for the transplant. And we think that that combination of this very aggressive treatment with the transplant is why we can be successful in getting patients a long-term chance at cure with this very difficult cancer. Sometimes we still can get recurrence even after a successful transplant. So we make it through the radiation, we make it through the staging, we make it through the transplant, and unfortunately the tumor can still come back. So when we look at recurrence, we see where does it typically come back. It typically comes back right in the area where the liver is, not necessarily in the liver, but in that regional area. So that it can also occur in distant sites, but primarily it comes back in the area. These that have recurred in distant sites are probably had already spread even before transplant. How can we know if it's likely that a patient will not make it to transplant? We've actually worked pretty hard to try to figure out what these predictors might be, just so that patients can have a better idea of what is likely to happen for them. And we have been able, in looking really closely at the patients we've treated, been able to identify who's not likely to make it all the way to transplant. And if you have a very high tumor marker that doesn't get better when we put stents in, that's a risk factor for not going all the way to transplant. It's not precluding transplant. It doesn't mean that just because you have a high tumor marker, you're not going to make it to transplant. What it means is that patients with a high tumor marker have a higher risk for not making it. Similarly, things that make you a higher risk for not making it would be having a large mass or having very advanced liver disease, even having a positive biopsy, because this just likely means that the tumor is a kind that's more advanced and it's starting to have more cells, and it's easier for us to get a sample of it, and that's why that would be a negative risk factor. Again, this doesn't mean that patients are not eligible for transplant. It just means we're going to be more worried about getting them all the way through the protocol. And what about patients who might be at risk for recurrence after the transplant? So we've had 25 patients who've developed recurrence after the transplant. And we look at them from two different time points, from where they present, meaning their first visit to the clinic, looking at how they're doing at that time. We can see that those whose tumor was circling around the portal vein, that is a risk factor that carries even to recurrence, a risk of recurrence after transplant. We also see, again, if they have a very high tumor marker that doesn't come down with the therapy, that's a little bit of an indicator. It's not a very strong indicator. As you can see, that hazard ratio is not very high, but that is something we would worry a little bit more about. The strongest predictor from the time of transplant, so once we've taken out that liver and we see that picture that I showed you earlier with the radiated liver, if we see a lot of tumor remaining in that liver, that's a bad sign. If we see just a little bit of microscopic residual, meaning that there's been an excellent response to the radiation, we know that the risk of recurrence will be quite low. But if there's a lot of tumor left, then we get concerned. And actually, based on this finding, we've started a protocol offering additional therapy after transplant called adjuvant therapy. And this would be only offered to patients who are at the highest risk of recurrence. And our hope is to prevent recurrence after liver transplant and reduce this risk for these patients who've had recurrence. Another question that we often get about this protocol is, has this been replicated outside of Mayo Clinic? Are other centers able to be successful with this protocol? And the good news is that yes. We looked at this closely, and in 2012 we looked all around the United States, and we were able to identify 12 centers who are actively enrolling patients, and we were able to find, at this point in time, 214 patients who had been treated and gone on successfully to transplant. And looking at all the centers, we were able to see a very similar outcome to what we're seeing here at Mayo Clinic with 70% 5-year survival. This is 65% 5-year survival for all of the patients in these 12 centers around the United States. And when we look specifically at the data, and if they followed the sort of same standard criteria that we're using here in Rochester, they had the exact same outcome, 72% 5-year survival for the whole. So excluding these patients that had had the kind of biopsy that we think is risky, or if they've had already metastases at the time of transplant, or if their mass was very large, those patients did poorly. If we take those patients out, then we have 70%, more than 70% 5-year survival. So the answer is yes, this protocol can be done outside of Rochester, and many sites, many centers around the country, it's being done successfully. But it's really important, a couple of important considerations. And again, you can see this is actually a liver that has been removed after transplant, and this is what the pathologist is looking at. And again, you can see these bile ducts are very scarred and very damaged from the radiation with bile stuck in them, and that's what this picture shows. That if you have the radiation, it's not possible to go on to resection. If you have this very high dose radiation that we're using, it's possible to use a lesser dose and safely do resection, but resection really would not be safe after the very high dose of neoadjuvant therapy that we're using for the protocol. If a patient has an attempted resection, we found that that really compromises the outcome of the radiation and subsequent transplant. So it's really important to try to make the decision about whether we're going to go with resection or transplant before we start either of those therapies, because it's really not possible to change our mind after we've done the radiation, I think we should go for resection, because after we've had that aggressive radiation, resection is no longer possible. It's also important to note, if you're trying to do a resection and you find that it's not successful, to try to send the patient now for transplant. If you've gotten involved where the tumor is, that again will compromise the outcome. So it's really important to try to make these decisions, but they're very hard decisions to make. So the take-home points that Hilar Cholangiocarcinoma is the most common type of cholangiocarcinoma, and it affects about 1 in 100,000, as we spoke about earlier. The primary risk factor is PSC in Western countries, although most patients, as Dr. Rizvi told you earlier, have no identified risk factors. And the typical symptoms include painless jaundice, meaning turning yellow without any other specific finding, or weight loss and abdominal pain. The diagnosis can be tremendously challenging, and it relies on a combination of imaging studies as well as trying to obtain cytology, and we can even do a technique called fish analysis.
Outcomes with resection are, with resection alone, meaning just surgery, and we're not talking about liver transplant here, are about 25 to 30% overall 5-year survival. Combined neoadjuvant therapy, which is chemoradiation therapy that Dr. Heimbach discussed earlier, followed by liver transplant, has favorable results, and that's a 69% patient survival at 5 years. Risk factors that predict dropout as well as recurrence after being, for patients who have been in this protocol of chemoradiation followed by liver transplant, we have identified those risk factors, and one of the primary take-home points is to avoid a transperitoneal biopsy of the primary mass. So we never biopsy the mass itself.
Except through the bile duct at
Except the ERCP, yes. And the liver transplant protocol is for early stage unresectable cholangiocarcinoma, which occurs in the de novo setting, meaning there's no underlying PSC, or any perihilar cholangiocarcinoma arising in the setting of PSC. And in this case, staging of the tumor is essential prior to enrolling patients in the liver transplant protocol.
And now we're going to open up this forum for questions that may come from the people watching the webinar. We're just going to get those questions loaded up now.
So the first question is, with a benign narrowed hepatic duct high up in the liver, would you operate even though it is difficult? Or do a transplant if the person has been in severe pain for 19 years? I know a narrowed hepatic duct may not cause a change in blood tests. Can people have cholangitis without it affecting their blood tests? So I think Dr. Heimbach, you want to tackle the first part, and I'll tackle the second?
The first part about this question is if there's a narrowing of hepatic duct high in the liver involving only one side of the liver, this would require resection of that side of the liver. That is a major surgery that does have risk. So the risk to undergo that surgery would have to be considered very carefully in the line of benefit of that surgery. So typically, if the lesion is just on one side, transplant would not be needed, because transplant is when we can't just remove the problem. So transplant should not be needed. Transplant is a much more aggressive therapy, actually, than removing one side of the liver. So if that would thought to be beneficial to be removed for treatment of pain, it could be considered, but it's a big operation, so that would have to be considered carefully in light of the benefit.
And the second part of the question was whether a narrowed hepatic duct may cause changes in the blood tests, or whether blood tests change when someone has cholangitis. The answer to both of those is not necessarily. So patients can have blockages of their bile ducts without having a significant rise in the bilirubin. And we do have patients who develop cholangitis, which is infection of the bile ducts, without having any significant change in their blood tests. And the primary blood tests that we would be looking at here are bilirubin, which I mentioned earlier is a substance that is found in bile, and an enzyme known as alkaline phosphatase. So to diagnose cholangitis, actually, the criteria we use is primarily clinical. So our PSC patients who present with fevers, chills, and or abdominal pain, for us, that is more helpful than the bilirubin changing from, let's say, 2 to 3 or 3 to 4.
So there's a couple more questions here. One is whether liver transplant is an option for other types of cholangiocarcinoma. There are data now for the use of transplant for intrahepatic cholangiocarcinoma, but this data is very preliminary, meaning it's just not very much information available about this. So at this point in time, that would not be the standard treatment for intrahepatic, although maybe in the future there'll be additional information about this. For patients with distal bile duct cancer, meaning the tumor is way down at the end of the bile duct, transplant is really not something that we consider in that situation, because typically it's possible to remove the tumor without needing to remove the liver. So I'll take this next question as well, which is about resection. And the question is a very challenging question, and it's, my tumor is resectable. Would it not be better just to go for a liver transplant now? The reason that this question would be asked is that the survival with resection is typically around 30%, and when you see the survival with transplant being 70%, it seems like, why wouldn't we just do transplant for everybody? And so this is a complicated question. The most important thing to remember is that the 70% survival only applies to patients who make it all the way through to transplant, which is not every patient. And some patients progress with infection or have other problems that make transplant not an option, or the tumor spreads while they're waiting. So there's a critical shortage of available organs for transplant, meaning that makes us have to wait a long time to get access to transplant, and things can happen during that waiting time. The other issue is that if the tumor has spread to the lymph nodes, transplant is not an option, whereas resection is still an option. So far, we've really only applied this protocol to patients who have resectable or to have unresectable, no other therapeutic option, because of all the other risks associated with transplant.
The next question is there an age limit for liver transplant? We don't typically say that we have a hard, fast cutoff. What we do look at is how old a patient is, what are their other medical comorbidities, meaning what other medical problems they have. So for instance, if we have a very healthy 69-year-old, we wouldn't necessarily say that they're not eligible for a liver transplant. On the other hand, if we have a 65-year-old has very bad heart disease, lots of other problems in addition to their cancer, then we may have to think very carefully before saying that this is somebody who would be suitable for the liver transplant protocol.
And the next question is in a similar way. Is there an age limit for a living liver donor? So living liver donor refers to the possible chance for somebody to receive a transplant from a living person. So that's a possibility. How does one get a liver transplant? We can consider that question in two different ways. You either can have a deceased donor or a living donor transplant. Living donor transplant is possible because even though the liver looks like it's just one big thing, on the inside it actually has two sides, a right side and a left side. And the whole operation relies on the fact that if we remove one side of a healthy person's liver, the remaining side grows back very quickly. So that whole process of regeneration actually slows down as we age. So the bottom line is, yes, there is an age limit for living liver donors, and that's because of that slowing down of the regeneration process as we age. It makes it unsafe for somebody, or less safe for somebody, to be a living donor, and it also makes it less safe for the recipient of that living donor graft because it grows back more slowly. So most centers have an upper age limit, and looking around the world at centers that do living liver donation, it varies between 50 to 55 or 60. Those would be the general upper age limits for living liver donors.
The next question is, what is your opinion on the role of dietary nitrate intake as a risk factor for cholangiocarcinoma? So dietary nitrates, intake of that, or high intake of that, has been associated with other types of cancers such as stomach cancer, but has not been studied or been known as a significant risk factor for the development of cholangiocarcinoma, especially Hilar Cholangiocarcinoma. As I mentioned earlier, most patients with Hilar Cholangiocarcinoma actually have no underlying identifiable risk factor.
So the next question is, how important are waiting times for a cadaveric transplant? And what this means is a deceased donor transplant. And waiting time is a critical issue when we're talking about liver transplantation. Right now in the United States, there are about 16,000 people who are listed and waiting for liver transplant. And every year we have an opportunity to do a transplant for only about 6,000 of those patients from what we call deceased donors. So there are only about 6,000 deceased donor livers that become available each year from individuals who've had devastating injuries and their families, and they have agreed to proceed with organ donation. And unfortunately, we just don't have enough of those available donors to serve all of the people who need transplant. So waiting time is a critical issue. One of the ways that we can help with that is to consider the option of living donor transplant, which can be very effective in patients with Hilar Cholangiocarcinoma. And in fact, anybody that is going through the protocol, we would definitely favor that approach if it was available to them.
So the next question is, why does Hilar cholangiocarcinoma mostly affect older people? Hilar cholangiocarcinoma can actually affect all age types. We typically don't see a lot of PSC patients in the pediatric population presenting with Hilar cholangiocarcinoma, but we do have younger PSC patients in their 30s or 40s presenting with Hilar cholangiocarcinoma. Having said that, most patients who present with de novo Hilar cholangiocarcinoma, which means that patients who don't have an underlying risk factor such as primary sclerosing cholangitis, a lot of those patients do tend to be older.
The next question that comes from the audience is, why do you recommend chemotherapy and radiation before the liver transplant? And this is an interesting question, and it actually, the answer to this comes from our experience that we actually tried that liver transplant all by itself for Hilar cholangiocarcinoma, and we found that that was very unsuccessful. Patients recurred really quickly. And today, we think that the chemotherapy and the radiation therapy is really important in preventing that tumor from coming back really quickly. And as we can demonstrate with our outcomes today at about 70% 5-year survival compared to what we had before when we tried this without the radiation therapy, which was only at about 5 to 10% 5-year survival, we think that the radiation therapy is really important. We know from data that is available in patients who didn't know they had cancer, so patients went ahead to transplant for PSC, and later when they got the liver out, they found in fact there was Hilar cholangiocarcinoma. Even those patients are at very high risk of disease recurrence. So even when it's very early and we don't actually know it was there, those patients can recur a lot of the time. So that's why we really think that the chemotherapy and the radiation are so vital in having a good outcome with this tumor.
The next question is there anything I can do to slow down the progression of my tumor? So that's a good question. It's a broad question. I think it depends on what the extent of a person's tumor is. If somebody has a tumor limited to the liver, then we know that the chemotherapy and radiation therapy, especially the radiation therapy that we give before liver transplant in our protocol, it is very effective in causing shrinkage or even disappearance of the tumor. But as far as anything that a patient can do on their own, such as any dietary or lifestyle modifications, unfortunately, there's nothing that has been identified to be helpful.
The next question is, does a river...
I think it's liver,
not river, but they do live in the river, don't they, these liver flukes? Anyway, they come from waterborne areas, but this is a liver fluke infection. And does this increase the risk for cholangiocarcinoma? And if yes, can this person avail of liver transplant under the ideal conditions? And as we presented earlier, this is a risk factor for development of cholangiocarcinoma. And if this is Hilar cholangiocarcinoma, yes, this person could be treated with the possibility of neoadjuvant chemoradiotherapy and liver transplant if the tumor is caught at a stage where we know that transplant can be beneficial. Again, if the tumor has already spread outside of the liver, the transplant protocol would not be effective in that situation. But hopefully we could identify this early and proceed to transplant. The next question is, why is domino liver transplant not considered more frequently? And many of you may be wondering what in the world is a domino liver transplant. It has nothing to do with pizza, but what it has to do with is actually taking the liver from one healthy individual who's having a liver transplant for a different reason, and this is then given to somebody else. So there are individuals who have conditions where their liver is perfectly normal, but it's making got a metabolic condition where it's making something such as somebody that has a disease called familial amyloidosis. So they're born with this condition, and this condition progresses throughout their life, and the liver is making an abnormal protein called amyloid that can get deposited throughout the body. People usually don't have symptoms until they're well into their 40s or 50s. And then they present, and we diagnose it, and then transplant can help, liver transplant can help that problem. These individuals have perfectly normal livers, except the liver is making this abnormal protein. So we can actually take that perfectly normal liver and give it to somebody else who is older, who has liver disease, who needs a transplant and has difficulty accessing transplant. Because we think that their natural life would end before they would start to develop symptoms from this amyloid protein. As we know, it takes decades upon decades to start getting symptoms. So we currently restrict this to patients who are age 60 and more who need a liver transplant. And if we have a recipient who's having a transplant for amyloidosis, we can use those livers. There are not a lot of other diseases where this domino option is possible. And there are not a lot of patients with amyloidosis who are having transplants. So that limits the applicability of a domino liver transplant to more people. It's just simply the number of patients with amyloidosis, and there are not a lot of other conditions that could make this a possibility. But certainly, because of that critical shortage of available organs, we utilize every opportunity we possibly can to get patients transplanted successfully.
Okay, so with that, we will conclude. We want to thank you for your time and your excellent questions, and we'll try to answer any additional questions that we did not get to today in the following week.
Thank you very much for your attention today.